Good morning and welcome to the Alliance for Home Health Quality and Innovations webinar on the third working paper of the Clinically Appropriate and Cost-Effective Placement Project. My name is Teresa Lee and I'm the Executive Director of the Alliance. By way of background, I'll just tell you a little bit about the Alliance and today's webinar before we get started. The Alliance was founded in 2008 by leaders in the home health care community in the United States with a dedication to the mission of investing in research and education on the value proposition home health care has to offer to patients and to the healthcare system. The working paper that we will discuss today is part of a larger project that the Alliance has commissioned from Dobson, DeVonzo and Associates. This study is called the Clinically Appropriate and Cost-Effective Placement, or CACEP, project. The purpose of the study is to better understand the way home health care currently serves Medicare beneficiaries, and after attaining a grasp on the present, to consider how the Medicare home health benefit can better meet beneficiary needs and improve the quality and efficiency of care provided in the U.S. Dobson DeVonzo has done a deep dive into Medicare claims data and reviewed the literature to help us to answer these questions. In the context of this project, we're releasing 4 working papers containing descriptive statistics between now and June 30th, and then a final report in September. We released the first 2 working papers on episode frequency and payments in April, and you can find them on the Alliance website at www.ahhqi.org. Today's webinar is a pre-release briefing on the 3rd working paper, and the topic is patient care pathways. The Pathways paper, press release, and summary materials will be posted on the Alliance website by Tuesday. A 4th working paper on readmissions will be released in June, so stay tuned for that. Al Dobson of Dobson, DeVonzo and Associates will be providing an overview of the Patient Pathways paper today. Al Dobson is a health economist and president of Dobson, DeVonzo and Associates. Before he co-founded the firm, he directed the Lewin Group Healthcare Finance Group as Senior Vice President. He has served as Director in the Office of Research at CMS, and Dr. Dobson has testified before the U.S. Congress, MedPAC, and various state, federal, and presidential commissions on healthcare finance, provider payment, and health policy issues. Just a few housekeeping notes before we get started. First, Al will speak for approximately 45 minutes, and we'll leave the last 10 minutes to answer questions. Please note that this is a webinar and we are controlling the slides on our end, so don't be surprised if you can't flip ahead. Also, we'd like to request that you put your lines on mute. You can submit questions to be answered during our Q&A period through the Fuse webinar software on your computers or other devices. Just one warning about the Fuse software. If you send a question to everyone will see your question. So you can send a question to the speaker to be answered during the Q&A period by sending a question just to me, Teresa Lee. Finally, please be aware that we are recording this webinar, including the Q&A period, so that we can provide a playback on our website to those who were not able to participate live today. And with that, I'll turn it over to Al Dobson.
Thank you, Teresa. Starting on page 2, we have our presentation overview. We'll recap the project setup to start with. We'll give the purpose of the clinically appropriate and cost-effective CACEP study. We'll look at CACEP episodes of care, which are integral to how we do our analyses. We'll review our working paper series. We'll look at our data methodology in brief. I'll discuss why patient pathways are important. We'll say how they're important in terms of the amount of fee-for-service payments represented by our pathways, and then we'll look at 3 episode types. On page 3, the overall purpose of the CACEP project is to determine how Medicare home health benefits can better meet beneficiary needs and to improve the quality and efficacy and efficiency of care provided within the U.S. healthcare system. CACEP is a data-driven study that aims to answer a wide variety of questions. And again, we focus on 3 episode definitions as explained on page 4. On page 4, starting on the right side, the first episode definition is the post-acute care followed by an index stay. This particular episode is 60 days after the index stack. We call it the index stack or acute care hospital discharge. It's approximately equal to the BPCI, or the as mandated by the ACA. That's the Bundled Payment Care Initiative that CMS is undertaking, and they're using a definition of the bundle that's fairly close to the one we use in our study. Our second bundle is a pre-acute care leading to the index hospital stay. It's 60 days before the index stack admission. So the first one is after the admission, and the second one is before the admission. Type 3 is a very different kind of a bundle. It lasts 9 months after an index home health episode. So the first two are anchored in a certain way by an index hospital stay, either before it or after it. And the third type of episode is 9 months after an index hospital episode. So the total would be the index the index home health episode plus 9 months. We focus on episode 1 today, but we'll also make some references to episode 2 and episode 3. On page 5, our working series, as Teresa said, there'll be 4 working series papers and then a final paper. The first working paper series is frequency of episodes. The second one was Medicare expenditures. Those are both on the website, as Teresa said. Patient pathways, soon to be released as the working paper we'll discuss today, and it will be insight into the care trajectory of care provided to patients in the country as they either leave the hospital or come into the hospital or leave the home health care setting. Our fourth working paper will be on acute care hospital readmissions, and it will go in very much detail about how readmissions affect the care people provide in this country. We expect that our working paper statistics will be useful to policymakers. Indeed, our initial briefings to CMS and MedPAC have suggested that analysts are very interested in the kinds of information we've developed, and they will inform policymakers if they think their way through payment reform in the future, particularly as payment reform applies to the various bundled payment initiatives and perhaps a bit to the ACOs as well. Our descriptive statistics comprise a point of departure for subsequent quantitative analyses that will be in our final report. In that report, we'll explore a series of broad-based policy options. We'll look at regional variation, we'll look at high-use patients, and we'll look at the substitution of home health or facility-based care. The idea being we want to see how these kinds of broad-based policy options could affect Medicare savings. On the next page 6, this is a data-driven study. We've linked together the Medicare 5% file. We have all the Part A and all the Part B claims. We have no Part D claims at this point. We have no co-payments in our models as of yet, but we will in the future. We have claims we're linked across all site of service by a unique patient identifier. We have what's called the DUA, a data use agreement with the government, in order that we can use these data. All private, personally identified data have to have a data use agreement, of which we have. The unit of observation in our study is the patient episode over a finite time period, as I've just said, 60 days after an index hospital stay, 60 days before, or 9 months after the home health episode. Data were linked to other approved data sources. We have chronic condition warehouse data, which turned out to be very important, as we needed those data to be able to understand how to define our episodes that come before the hospitalization or after a home health visit. We have assessment data, which we've started to work with. They'll be an integral part of our final report. We have other kinds of data that we link as well when we do our econometric analyses in the final study. The database episodes are currently updated. We've continued to modify our thinking on the updates. We followed the CMS over the summer and the spring and summer as they put together their bundled payment initiative, and we're staying very current with the government's thinking on how episodes are defined. On page 7, we discuss why patient pathways are important. Patient pathway reflects a sequence of setting a patient enters within a fixed-length episode. It's a trajectory of patient care. Patient pathways are highly complex. Healthcare is highly complex, with some SDRGs and chronic condition exhibiting hundreds of unique pathways. But we note that care is concentrated in just a few pathways. So we have heavy concentration, but an enormous amount of heterogeneity in the way we provide healthcare in our 3 pathways. There's no way of telling from our data whether the complex pathways are clinically necessary or show a certain amount of poor quality. We suspect that the evidence suggests it's a bit of both, and that as we reform healthcare payment and delivery, we'll try to reduce the complex of patient pathways for many, if not most, patients. Under bundled payment, patient pathways will likely be simplified both clinically and financially. Indeed, as we've worked with the people who are applying for the bundles this summer and spring, I think the main focus is looking at the pathways and trying to understand how patients move from one setting to another and how that can be simplified and streamlined. In the little box on the bottom of page 7, patient pathways allow us to understand the clinical composition of episodes, which is critical to the success of payment bundling, as it allows for better care coordination, cost-effective mix of patient services within an episode. And of course, our study is about how home health care can be used in a more powerful way to meet these objectives. On page 8, the definition of patient pathways. Pathways comprise patient sequence stops over the length of an episode and are divided. We divide them into facility-based, including home health as a formal post-acute care setting, and ambulatory-based care. We have the index stack or readmission, which would be an acute care hospital. We have home health. We have inpatient rehabilitation. We have long-term care hospitals and skilled nursing facilities. On the ambulatory care side, we have community, where when we have a community, that could be any number of physician visits that are not otherwise interrupted by a facility-based stay. We have ER, outpatient therapy, hospice, and other inpatient. The initial setting is included in our average number of sequence stops, which we'll show in a minute. The average number of facility-based or home health and ambulatory-based sequence stops are presented by first setting, MSDRG, or chronic condition for each episode type. That is to say, in episode type 1, it's clinically defined by an MSDRG. Episodes type 2 and 3 are defined by chronic condition. We've used regression analyses preliminary to understand some things that might drive expenditure pathways, and we show you a bit in how that might work. On page 9, we make one point. I make one point, and that is that episode type 1 represents about 50%, 60% of Medicare fee-for-service expenditures. We would presume that would be about a comparable amount of expenditures for Medicare Advantage plans. That is to say, episode type 1, if they could be controlled, would have an enormous influence on fee-for-service medicine in this country, because about 60% of the action would fall within episode 1. For episode type 2, excluding the index stack, we have about 12%, and comparably for episode type 3. The obvious notion of this is if you have a hospitalization that anchors an episode, the 90 days, the 60 days that follow that are very intense in care relative to that period of time before you have a hospitalization, which just makes common sense. So now we're going to turn to episode type 1, post-acute care, 60 days following an index hospital stay. Page 11, we have our definition of terms. The post-acute care episodes are clinically defined by the index stack or the MSDRG. That is to say, the index hospitalization or the anchor hospitalization, that MSDRG that the patient is assigned in that hospital then defines the episode. As those of you on the line know that are in the business, you know that as you move away from the hospital, the relationship between the MSDRG of the hospital stay and admission to home health, SNF, IRF, or LTAC is much more tenuous as time passes. It's just a fact, though, that the only way we can define an index stay is the MSDRG, and that's how we define it in our analyses. The index stack, the acute care hospital stay that initiates the episode, is also referred to as an anchor admission in the Bundled Payment for Care Initiative, the BPCI. The first setting is that setting that the patient moves to immediately upon discharge or within a number of days of discharge from the index or anchor stack. And we have defined the first setting by the stack could be a readmission, home health, SNF, IRF, LTAC, community, ER, outpatient, hospital, and other inpatient. The way this works is if you're in the hospital, you come out of the hospital in a post-acute care episode, the episode is defined by the index stack, MSDRG, and then the first setting you go to, if it's home health, that would be a first setting home health defined by an MSDRG. We'll see how that works as we go through our pathways. On page 12, we make a point that our episodes that we define as the post-acute care episodes are, roughly speaking, are comparable to the bundled payment for care initiative that CMS is engaged in this spring. We note that we have the bundled episodes. Ours include the medical payments, disproportionate share payments, and capital. BPCI does not. Probably the major difference as of now is that we do not include co-payments and deductibles. Neither did BPCI until 4/1/12. Then they decided to include the co-payments and deductibles, as will we when we finish up our study in the fall. Aside from that and some other issues, our payment and our post-acute care episodes and the BPCI episodes are roughly the same. They have the same notion that you go to a hospital, you come out, and you follow the care for some period of time. Page 13 are key findings for our post-acute care episodes. The home health first setting episodes have more ambulatory-based sequence stops and fewer facility-based or home health sequence stops than other formal care settings, those being SNF, IRF, LTAC, and SAC. This results in lower average Medicare episode payments, which is kind of common sense. If you go to the least cost settings, your care will be less expensive than if you go to more expensive facility-based care. Approximately half or all of the episodes within and across MSDRGs are represented by the 5 most frequent patient pathways, while literally hundreds, if not thousands, of pathways exist across the various MSDRGs. The most frequent pathways have lower than average Medicare episode payment, suggesting that efforts to streamline patient pathways based on clinical guidelines could result in Medicare savings. There seems to be an emerging consensus, at least at some level, that simpler pathways are very common. They're the most frequent. But then again, we have an enormous amount of heterogeneity in how people are treated as they come out of the hospital, dependent upon first PAC setting, depending upon the MSDRG, which they were assigned in the hospital. As the number of chronic conditions per episode increases, the number of facility-based or home health stop increases relative to the ambulatory stops, the extent to which varies by MSDRG. Episodes that contain a hospital readmission have twice as many sequence stops as episodes that do not. That is to say, if you have a readmission, it essentially starts the counter over again, more ambulatory care, more facility-based care, twice as much care than if you do not have a readmission as you come out of the hospital. Episodes for patients who live alone or died have slightly more severe sequence stops and are slightly more expensive. On page 14, we move to our first numerical issues. What we see is that the average number of sequence stops by first setting, we show that on the far left that home health has an average sequence stop of 4.37. SNF has an average sequence stop of 4.12. That's SNF first PAC setting on down for an average overall of about 344 sequence stops. On the left, we see that the value of the the amount of Medicare paid at home health at $23.45, it increases for a SNF first stop to almost $30,000, an IRF first stop of $44,000, and an LTAC stop of $89,000. A readmission is $29,000, which is, in this case, approximately the overall average. The average number of sequence stops overall is 3.44. For home health, it's 4.37. For SNF, it's 4.12. Again, a sequence stops is the number of places a person goes, including the index hospitalization, as one leaves the hospital. When we look at home health first setting, in the red on the upper right corner, we see that home health has 277 facility-based or home health stops and 160 ambulatory stops. If you take out the home health, which is in many ways more ambulatory than it is facility, those numbers change to 177 and 260. That is to say, home health would be much more ambulatory-oriented, of course, than a facility-based stop, a SNF, an IRF, or an LTAC. Again, that explains a lot of the difference as you move from the $20,000 to $30,000 to $44,000 to $90,000 for the episode cost as you move down or up, move across the first settings. Just a small note that the outpatient therapy has 341 stops, which we can see on the right side. That is to say, there's a fair bit of outpatient therapy relative to the overall number of stops, which is 344 for our post-acute care episodes. Again, our payments do not include Part D or patient co-payments, so the relatives, because we don't have the co-payments, the price relatives will actually spread a bit more. Home health does not have a co-payment. SNF, IRF, and LTAC do have co-payments. When you add the co-payments in, those relatives or the difference in prices across the settings will spread more as the co-payments are added. On page 15, we look at the most frequent pathways. Again, most of the patients go through just a few number of pathways. We see on the far left, we see AC, AHC, AC, AAC. All that means is all of these pathways are anchored by an A, or an acute care hospitalization. Z is community, any number of physician visits, and H is home care. So we see that some combination of AC or AHC gives you your pathways. There's a little check on the left, which means one of the most frequent pathways for post-acute care is an ACA, where somebody starts in the hospital, has a community a physician visit or an outpatient visit, returns to the hospital for a readmission. But you see that's only 2.8% of the total, where the most common pathway is the hospital into the community, 34%, with an average of $10,000 spent. So the second point to make on this slide is that 52% of our all pathways are represented by the 5 most common pathways. They average about $13,000. The remaining 47% average about $27,000, with an overall average of $19,000. The point to be made here is that simpler pathways cost less, or complicated pathways cost more. If we can simplify our pathways, we can reduce expenditures on patients as they come out of the hospital setting. On page 15, again on the right side, we note again that the most frequent pathways for each setting would be a hospital plus home health for home health. For SNF, it would be a hospital plus SNF. For IRF, it's hospital plus IRF. And for LTAC, it's hospital plus LTAC. That just makes sense because that's the definition of the first PAC setting. Again, note that we move from 16,000 to 25,000 to 37,000 to 96,000 for these first PAC settings as we move from a home health ambulatory setting on into the facility-based settings of home health, SNF, IRF, and LTAC and the readmissions. Page 16 makes a couple points. The first is we note that on the very bottom, the axes go from 0 to 15. That's the number of chronic conditions. As the number of chronic conditions increase, logically enough, so does the number of the average Medicare episode paid in blue, the average ambulatory sequence-based stops in green, and in the red, I guess it is, the average facility-based sequence stops increase. So as you move from left to right, the episodes are more complex, they also have more frequent stops, and as we've noted, they also get more expensive. In the longer run, as people are looking through the bundling process, they're contemplating how they can move the number of facility-based down, have more ambulatory care up, that is to say, to substitute ambulatory care for facility-based care, and presumably to shift the blue line down, even as you have more episodes, if you can substitute less expensive for more expensive care, simplify the pathways, you can reduce the amount of Medicare expenditures across these types of pathways. Page 17, we note that as we move from the right to the left, paid readmissions are twice as many episodes, from 2.79 to 5.68, twice as many stops, approximately twice as many expenditures. If you die during the episode, the complexity is a bit more, from 335 to 371 if you die. And if you live alone, your episodes are more expensive at 406, up from 325. Page 18, we look at MSDRG 470. MSDRG 470 is major joint replacement without major complications. We see an audit here, at least an interesting fact, that the number of ambulatory care stops actually falls as the number of chronic conditions increases, as we move from left to right. The number of facility-based episodes stops increases as the number of chronic conditions increases. And of course, Medicare expenditures rise as you move from left to right as the number of chronic conditions increases. One thing to note about MSDRG 470, it's discretionary, it's without complications or comorbidities, major complications and comorbidities, and it's surgical. As we move to page 19, we see a very different pattern. As we increase the number of chronic conditions, We see ambulatory increasing at a fairly steady rate. We see facility-based care increasing at a fairly steady rate. And we also see Medicare expenditures increasing at a fairly steady rate. We don't see the falling off of the green line or the ambulatory care, probably because this is non-discretionary, it has major complications and comorbidities, and it's medical, not surgical. On the far left, we see the little box, and the little box suggests that expenditures can be very high for people that show no chronic conditions. How can that be? Probably because as you come into the Medicare program, you have no history. You haven't been to a hospital or an ambulatory care setting to have recorded conditions, and that's where these conditions come from. The number of chronic conditions are historical capture of your medical records. If you're new to Medicare, if you have a major medical event, you could be very expensive, but the Medicare program wouldn't have had time because they hadn't observed you yet to count chronic conditions. So you could be a zero, a number of chronic conditions, yet be very complicated in terms of your expenses, and I believe that's what this shows. On page 20, what we have is, again, now we're going to look at our MSDRG 470, 291 heart failure and shock. On the left side, we see the 5 most frequent pathways for MSDRG 470. Again, they all start with A, the index hospitalization. They move through the various settings, and the first one is a hospital, home health, community. The second one would be hospital, SNF, home health, community. We see that they're highly concentrated, just as they are overall. The second point we note is that about 48% within MSDRG 4 setting of the pathways, the 5 most common pathways represent 48% of the pathways. Also, here we note that at $20,000, the remaining episodes are $25,000. We don't see near the spread here, probably because MSDRG, again, is discretionary, it's surgical, and we have a lot less going on as we move to the most complicated pathways. In vivid contrast, as we move to 291, heart failure and shock, we see that the 5 most common pathways are tightly clustered at 45%, slightly less than for MSDRG 470 at 4.4%. But as we look at the far right, we see $13,000 for the 5 most common pathways average, yet we see almost $30,000, over twice as much, for the remaining pathways. That is to say, for this non-discretionary medical condition with complications and comorbidities, as pathways become complex, they get very much more expensive. Perhaps that's a place to look for savings as we go into the bundling initiatives. If we can move people down to the more simplified pathways, perhaps we can save money for the Medicare program. Page 21, we look at readmit and no readmit. The only point I'd like to make on this page is that the pathways are much more complex between a no readmission and readmission on the right bar of the pairs. And for 470, 871, which is septicemia, 291, heart failure and shock, 003 is trach, and 194 is simple pneumonia. Very, very different conditions. All show the same phenomena, that if you have a readmission, it essentially doubles the number of pathway stops and doubles your expenditures. Readmissions, of course, are complicated. Some could be unplanned, some could be unnecessary, some might be able to be reduced. Others might simply be sicker patients or planned elective surgery, as we saw with 470. So we have to be careful about saying that we can reduce readmissions easily and frequently, but at least in some instances, I think the facts on this page suggest there's money for Medicare to be saved, as Medicare has noted in its hospital regulations, that some admissions are perhaps unnecessary. And if you reduce them, not only do you reduce the readmission, but you reduce the patient pathway complexity as well for more market savings than you'd guess. It's not just the hospitalization you save, it's all the attendant care that follows along with a readmission. On page 22, we note that lives alone status also travels across each of these 5 MSDRGs. Not by much. The pathways are complicated more so for 871 than from some of the others, but a slight increase in pathway complexity and presumably expenditures for folks that live alone as opposed to do not. Now we're going to turn to episode type 2, pre-acute care episodes. To refresh, that's 60 days before an index hospitalization. On page 24, we make a very important point to nomenclature, and that is that pre-acute care episodes are clinically defined by a primary chronic condition, which is ranked by severity. The way we did that was we went to the chronic condition warehouse, which is where these data come from. We got a corresponding, we got a condition, and there are 21 for each chronic condition. There are 21 in our claims. We then mapped it to a corresponding what's called an HCC, or hierarchical condition category, and we pulled those from the Federal Register for MA, and in effect we blended the way Medicare pays for Medicare Advantage, and we were able to put every patient in a mutually exclusive categorization, and we'll see in a few pages how that works. But it's a hierarchical design where every patient is in one box within one categorization of the episode. And again, I'll show you that in a minute. What we find? On page 25, excluding the index care hospitalizations, the average pre-acute care episode contains fewer than 2 sequence stops, very much less than the other of the post-acute where we had 4 stops, primarily because these folks haven't gone to the hospital yet, they're not as sick yet, and the majority of them which are ambulatory care-based. The most frequent patient pathways, that would be community and A, they all end in A in this case because the index hospitalization ends the stay now as opposed to start it, represent more than half of all episodes. So one pathway represents half of all episodes, and the top 10 pathways represent 80% of the action, so to speak, in terms of pathways. Very much a concentration of how people are concentrated in pathways when you look at pre-acute as opposed to post-acute. Again, though, if you have a hospitalization before you end this episode with the hospitalization, you have the episode contains twice as many sequence stops as done an episode that does not have a prior hospitalization. Episodes for patients who died during the episode and or dual eligibles have a slightly higher number of sequence stops. Now let's look at the tables that show some of these findings. On page 26 on the left, we see primary chronic conditions. The first and highest one is congestive heart failure and COPD. It's what we call an interaction between those two conditions. As all of you in the audience know, conditions travel together for the Medicare population, and Medicare indeed found that when you have congestive heart failure and COPD, diabetes and congestive heart failure, or congestive heart failure and renal, you tend to have be more intense. And as you can see, the number of average stops, even though people don't start with the hospitalization, are at 316, 30, and 293, are slightly higher than somebody with heart failure alone with no other condition, which has 2.68 average frequent stops. In terms of the lumping of people, or where the folks are, we see that about 25% of the patients that we see are CHF and COPD, 13% are diabetes and CHF, moving down to osteoporosis, that's about 15%. And again, because of the hierarchical nature, osteoporosis would also be combined with Alzheimer's disease, heart failure, and other kinds of diseases that were lumped up into osteoporosis. Second point to make on this is that, again, that the average overall is about 2.87 of sequence stops, and if you take out the hospital stay that ends our pre-acute care episodes, that would be 1.87, a fair bit less than the post-acute care. Again, there's about an even mix between ambulatory stops and facility-based stops, as we can see looking at the right-hand side where we list the number of stops. The point to make here is that healthcare is very complicated, patients are very complicated, they have many diseases, and they have many different pathways, but the pathways in this, as we see in a second, are very highly concentrated. For instance, on page 27, we see that overall almost 10 frequent pathways, only 2 of these have a hospitalization before the index or ending hospitalization. Most of these are much more straightforward. For instance, the first and most highest common pathway is community, and the A, which would be the ending hospital stay, that's 56%. So half of the patients see physicians and end up in the hospital, and they average $11,603. On the other hand, for those folks that aren't in the top 10 pathways, they have a $20,000 average, again suggesting that perhaps you can move the complication of the pathways down. And as you see those pathways that are checked, they have high expenditures, $23,000 for CACA, that is to say community hospital, ending in hospital at $23,000, $24,000, and ACA would be a hospitalization, community stay, then ending in the hospitalization at $20,000, which is just about the other average. So we see again that if you have two hospitalizations, you're very much more expensive than if you have a community and then end up in the hospitalization, which is the definition of this particular type of episode. When we look at page 28, we see that first we note that the number of chronic conditions increases from 0 to 15. We note with the red bar now being average facility-based stops, is slightly less than the number of ambulatory-based stops, which is somewhat higher. And we see a less intensive slope. As you have more chronic conditions, your increase in expenditures doesn't increase as rapidly as it did for the post-acute care, because these are pre-acute care episodes where folks aren't really exhibiting the exacerbations of having an increased number of chronic conditions. Again, we'd like to keep people out of the hospital if we can. If we look at the pre-acute, perhaps one of the things we can do is keep these trajectories flat and do our very best to keep people out of the hospital. On page 29, we have the average facility-based home health and ambulatory sequence stops by dual eligibility status. This will probably surprise many of you in the room because the bars aren't that far different as we'd expect. We think there's two reasons. Number one, there's no long-term care support services in our data because we do not have Medicaid data in these analyses. They're all Medicare data. And number two, this doesn't have the fact that dual eligibles, that is to say people that are on both Medicare and Medicaid, they may have more episodes, but any given episode they have isn't that much more complex than a non-dual. Again, that's an interesting finding. The duals are slightly more complex in their behavior in our pre-acute care episodes, but not as much as at least I would have expected. Many people have seen these slides say, gee, that's a surprise, probably because, again, we don't have Medicaid in the data, and we're not picking up the fact that duals probably have more pre-acute care episodes. Not necessarily each one's more expensive, but they just have more of them. Episode type 3, non-post-acute care community-based episodes. Again, this is 9 months after an index hospital stay. It's a very different kind of episode. We have to think about it very differently. It's 9 months after an index hospital, an index home health episode. The definition of terms, just as we did with our post-acute care, our non-post-acute care, we have pre-acute. We have primary chronic condition that defines these episodes, just as we did with our number 2 type episode. What we found on page 32 is that overall, non-post-acute care community-based episodes contain a similar number of facility-based or home health and ambulatory-based stops. The 10 most frequent pathways are less concentrated than other episode types and represent about a third of the episodes, as opposed to where we just saw in the number 2 type episode where it was 80%. The most frequent pathways mainly contain only home health and community care, which indicates that home health may be able to keep patients safe at home with the coordination of physicians. So we'll see a lot of combination of community and home health in our episodes. That's the most frequent, primarily driven because we started with the home health, but that was purposely done because we wanted to see the interaction of home health, community care, and physician care with these episodes, with the idea of eventually being able to use these kinds of episodes to perhaps reduce facility-based care. As the number of chronic conditions per episode increases, the number of facility-based or home health and ambulatory care sequence stops increases, just as we've seen with the other episodes. Episodes that contain a hospital admission have twice as many sequence stops as those that do not, even within 9-month episodes. And that patients who die or are dual eligibles have slightly higher average sequence stops, more complex patient pathways than those that do not. Page 33, again on the left we see CHF, COPD, diabetes, congestive heart failure, and renal. Diseases travel together. The more of you that you have together, the more complicated you are, and the more complicated your pathways are. Here we see the pathways almost doubling. for other, which are the less intense disease categories, at 602 in the middle, all the way up to 11 pathways for CHF and COPD. These things are essentially hierarchical. As you move up, the number of pathway stops increases. It's not totally hierarchical, but by hierarchical, I just mean for each time you move a line up, it should have a higher count in pathways. It doesn't uniformly, but primarily it does as you move from 6 to 11 pathways. Again, there's a high concentration of people at about 24% at CHF and COPD, 15% of diabetes and CHF, and we have a large number of people in osteoporosis, and rheumatoid and osteoarthritis, again, have a large number of folks in them. So we see a large concentration of people both in the number of the kinds of diseases they have, and as we'll see in a minute, in the types of pathways they have. On page 34, we note now a lot of HCs. And HC means all of these starts with home health, that's the definition, but we see a lot of Cs, community. Community can be physician or in the outpatient therapy setting. And the second one, we have an HC. We define these a little differently. A C is, we have an H, anytime a home health is interrupted by a physician visit, we break that. So on the second most common pathway, we have home health, physician, home health, community, or physician again. This isn't the way you usually think of home health as a 60-day episode. That is not what we've done here. We've said every time there's a physician visit, we break it, and we have a home health segment. We did that because we wanted to understand better the relationship between physician care and home health care. And as you can see from these, within the top 10 pathways for our non-post-acute care community-based episodes, they're totally dominated by the relationship of home health and community care, which we think is an important finding. We also note that for the top 34% of our episodes, the average is $9,000. The remaining 65%, the average is $32,000. Again, a finding that we repeat. As pathways become more complicated, as you move into facility-based care, expenditures become much more pronounced. Now on page 35, we have again the relationship between average ambulatory-based, average facility-based sequence stops, and average Medicare episodes as the number of chronic conditions increases, moving from left to right, from 0 to 14 plus. In this instance, you'll see they're more tightly clustered. As ambulatory green increases, as facility-based stops increase, they're very tightly clustered with a little bit of a flattening out at about 11 chronic conditions. They're rising very steeply, meaning that as you have more chronic conditions, your expenditures, at least your frequency stop, increases, as does your average Medicare episode paid, as shown on the left. So what have we found so far? The variance in on page 36. The variance in patient pathways is primarily a function of select patient demographics and the presence of acute care hospital readmissions. We have no functional status in these data. When we put functional status in, I believe we're going to say the variance of patient pathways is primarily driven by functional status and patient demographics and the presence of acute care rehospitalizations. Working papers 1, 2, and 3 focused on the frequency of episodes, the associated Medicare payments, and the distribution of care settings across episodes. Our major findings in our pathway, of course, is what we've shown you today, is that there's an enormous variation in pathway complexity. Those patient pathway complexities increase as you move into facility-based care, particularly readmissions. Our final working paper will analyze the impact of hospital readmissions on total episode payments. As we've seen, a readmission doubles the complexity of the pathway, doubles the expenditures, and will show in great detail in our final paper so many relationships of how that works. Our final report will consider potential impact of streamlining patient pathways through transitional care and core coordination on hospital readmissions on Medicare episode payments. The way we'll do that is we'll look at regional variation, we'll look at substitution of low-cost for high-cost settings, we'll look at reducing care for high-cost individuals, and again, we'll tie that off with how that will impact on savings of care. Right online at 11:48. Teresa, you're on.
Great. Thank you so much, Al. Just so content-rich in terms of his presentation today. And I want to just remind everybody that if you have questions, you can submit them through the Fuse webinar window on the lower left-hand side, and just submit a question to me directly. But while we're waiting for questions, maybe I'll just go ahead and ask you a question myself. It's striking to me that whereas some of the most frequent pathways might be somewhat streamlined, as you know, the rest tend to be somewhat heterogeneous and complex. And I guess my question is, sort of thinking about the big picture of the overall working paper and all of the data and analysis that you've done here, what do you think are some of the key takeaways or implications for the home health community to really think about based on the working paper?
I think that the biggest issue for home health, and particularly if we look to the VA program, which has used a lot of home health simplifying pathways and taken very complicated pathways and reduced their complexity and reduced the VA expenditures, Veterans Administration expenditures, I would hope that home health could show a lot of leadership in understanding how pathways work, how home health and the physician community can tie together, and to understand how pathways work, and to get a sense not only within your own immediacy of an individual home health episode, but across home health episodes, to try to understand better how patients transition from one setting to the next, and to use home health as a powerful advocacy platform for reducing the complexity of pathways and reducing the expenditures associated with pathways as we move through time. And I believe there's a lot of potential for that, and what our data show is that, by and large, most patients have simplified pathways. A few have very complicated pathways, and maybe home health can lead the way to showing how we can reduce the complexity of pathways for some, if not many, patients.
That's terrific. I do think that this is such a challenging area, and I think the more I think about this paper, the more I think that it highlights that there are true areas that we need to research further in terms of determining who should go where and when, which is sort of, in a way, what we're really addressing in terms of the big picture policy-wise in this report, and it's why the project is called the Clinically Appropriate and Cost-Effective Placement Project. There is this sort of question of, what's the clinically appropriate place for patients to be in and to place them there in a manner that's the most cost-effective and efficient for the healthcare system. I still don't have any questions from our window. I think that we've overwhelmed people today. I want to encourage people again one more time to submit any questions that you have through the meeting chat window at the bottom left. And want to also just remind people that we are recording this webinar so that others can hear about it, hear the recording later on. We'll have the final paper and summary materials and press release all issued on Tuesday. Last call for questions. Do you have any parting remarks?
My final comment will be that pathways are complicated. This presentation has been complicated. But the pathways allow us insight into how we provide care in this country. And as we gain better insight on how patients transition from one setting to the other, and as home health care gains insight into how that happens, I believe we can have powerful changes in how we both pay for health care and how we provide health care in this country. And patient pathways, I believe, are a way to start thinking about how we can do that.
Great. I want to just say that for the Tuesday, we do have one question. Okay. One question here is, how can providers use this information for the HRRP focus? I guess I'm not really sure what HRRP focus is. Let me ask the second question, too. MedPAC says that agency profits are 17%, and how do these figures show that costs are really still reduced? I'm not sure if anything here goes to profit margins.
Yeah, I don't believe our analyses go to the profit margins per se. We're looking at how care is provided across various settings.
The HRRP is Hospital Readmissions Reduction Program.
Oh, yes. These data really go strongly to hospital readmissions program. It shows that when there's a reduction in readmissions, not only do you reduce the readmission itself, you reduce all the ambulatory care and other facility-based care attendant to a readmission. It suggests that a readmission program could be very important, and as we'll see when we do our final paper, readmissions are fairly frequent across all first PAC settings. We all have a lot of work to do, but there's a lot to be gained as well. And I think that one thing I've noted when I've worked with the bundling initiative people, we're helping people with their bids. People ask two questions at a fundamental level. One, how can we reduce readmissions? And two, how can we simplify pathways and substitute the less expensive ambulatory-based and home health care for the more expensive facility-based care? And as they think about their bid prices, they're really thinking about, can they do each of those things with enough vehemence that at the end of the day they can come in under their bid price. Fewer readmissions, less facility-based expensive care lowers your cost of production relative to your bid price, and that's a happy place to be if you have a fixed price bid.
Okay, I've got a question from Warren Hebert. Says, Al, thanks for the robust report. Offer such rich information. Do you have other suggestions beyond simplifying care pathways? Are there other pieces that the VA model has plugged in that we might adopt? For example, hospital at home.
Yes, I believe that when we take a look at the phrase simplifying pathways is an amazing oversimplification of what has to be done. We have to look at care transitions. We have to understand where patients are most and best and efficaciously and economically placed. We have to think about the relationship between home health and care transitions. We have to think about medical homes. We have to think about eventually how ACOs may work as a platform from which all this can happen, or the payment bundling initiative, which I believe will look to home health care providers to help them reduce their costs for the payment bundles. There's an amazingly complex array of things that have to happen. The only thing we wanted to point out today was that if you understand the patient pathways, then you understand the challenges. Then you have to build the payment systems and the clinical systems that allow it to happen, which of course we didn't do today, but we laid out the platform where we can start to understand what needs to be done or what maybe can be done.
I think, too, that it's important to remember that when the C shows up, the community C shows up in the pathway, there can be many community visits strung together within that one quote sequence stop. And likewise, when there's an H, there might be many, many visits represented in that single home health segment. And, so when we talk about trying to simplify, I think that in a way what we're really talking about is trying to drill down so that where we're sending people, it's the most cost-effective place. So the most cost-effective place may be home health and community-based care, and it may be trying to rotate away from the more expensive settings that potentially are facility-based.
A researcher named Vincent Moore, many of you are familiar with Vince, makes the observation that patients are very fragile and at risk during care transitions from the community to a hospital, from a SNF to the home, et cetera, et cetera. And what Vince is arguing is that if we can reduce and pay a lot of attention to care transitions, which are implicit in all of our pathways, we reduce the risk for patients, and we make the patient care experience much more easy to navigate for the patient. It's a very important observation, I think. And Vince actually saw some early drafts of this, and he said, yeah, this is really important because it helps us understand better the relationship of pathways to the care process that patients undergo today.
Great. Well, my watch says that we're at the top of the hour. I want to just note that we will be sending out an email with the link to all of the final materials that are posted on Tuesday, and I want to thank everybody for terrific participation today. We had over 50 people on the line. Thank you so much.